And so now I'd like to introduce our first speaker. His name is Dr. Elliot Schuman, and he's certified by the American Board of Psychiatry and Neurology and received UCNS headache medicine certification. He's a fellow of the American Academy of Neurology, American College of Physicians, and the American Headache Society. He is adjunct clinical professor of neurology, Jefferson School of Medicine in Philadelphia. He has also participated and served as a mentor in the Palatucci Advocacy Leadership Forum. Dr. Schulman will speak to us today on the topic of update in migraine treatment. Please join me in welcoming Dr. Schulman.
Thank you very, very much for allowing me to be here today. I am truly privileged and humbled that I was invited to this gathering. I'd like to thank Shirley, Helen, and Katie for their undying enthusiasm in promoting migraine as a legitimate medical illness and one that has become more visible as a result of their efforts. They really deserve a lot of credit. My background as a neurologist took a turn about 25 years ago when I became interested in headache, and that's primarily what I do now. My role today, as I see it, is to give you a bird's eye view of what's happening now and what's new and what's happening and what's on the horizon. We're going to be talking about groups and new advances. My time is relatively limited, but certainly if you have questions, feel free to ask. So let's talk about where we are today, and then we're going to talk a little bit about tomorrow, and we can talk a little bit about the future at the end. So this is a slide which I like to talk about because when you go into your doctor's office and your doctor tells you you have migraines, I get sort of a stare at the other end of my desk and saying, hey, what are you telling me new here? The diagnosis of migraine is not difficult, especially for the educated migraineur, but this is something that we need to talk about. And we need to talk about it because migraine is a very disabling disease. That's why we're all here today. When you look at where migraine sits in terms of disability, it's at the very top. Can you imagine migraine is as disabling as psychosis, dementia, and quadriplegia? So, you know, I tell my patients, you're not going to die from migraine, but migraine is preventing you from going to work, it's preventing you from interacting with your family, it's preventing you from having the quality of life that we want you to have. Now, we've come a long way about understanding the genesis and etiology of migraine. But as hard as we've worked, we still don't understand all of the factors that contribute to migraine. I think it's important to point out that migraine is a disease of the brain. People think it's a disease of blood vessels. It affects blood vessels, but if it weren't for the brain, which is the genesis for migraine, the blood vessels wouldn't be affected. So I call this what's called in medicine an epiphenomenon. It's a result of what's going on. And we know that this is related to the fact that migraine brain is hyperexcitable. People in my office sit across from me with sunglasses on, and they are sensitive to motion and bright lights and sounds and odors, and that's because part of the pathology in migraine. We know that there are chemicals that are released. The important part of that is that those chemicals affect the blood vessels, and they make the blood vessels inflamed, and they cause the blood vessels to dilate. And those blood vessels contribute to the pain, and then once that sequence becomes generated, it's very, very hard to stop a migraine. That's why, for some of you, it's important to take your medicine early. This slide is sort of a recapitulation. The important piece is that there is a chemical that we've known about for a long time called CGRP, which I'm going to talk a little bit about. CGRP is really going to be the focus of the work that we're doing going forward, and I'm going to explain that a little bit to you. But CGRP is the chemical that probably causes the inflammation and the dilation of the blood vessels. So when you treat migraine, we treat migraine two ways. We treat it abortively. Doctor, I've got a bad headache. What do I do? And we treat it preventively. Preventive treatment is, you know what? I've got my headache 4 days a week. You gave me a great drug. My drug, I can only take 2 days a week. What am I supposed to do the other days? And by the way, my headaches, although they're better, I'm losing a lot of time from work and I can't attend social functions. That's when somebody needs a preventive. Somebody also needs a preventive when the drugs that they are taking, whether they be triptans or not, are not effective, or triptans are contraindicated. There are reasons that you can't take a triptan. If you have underlying heart disease, hypertension, you had a stroke, you have unusual migraines, and that's what we're going to be talking a little bit about today. There are two kinds of headaches. There are episodic headaches and there are chronic migraines. Episodic migraines are what most of us experience, but probably in this room there are a number of people who have chronic migraines. An episodic headache, and I'm just going to spend a minute on this, is a headache that has a definition according to the International Headache Society. It's one-sided, throbbing, moderate to severe. You need two of the four following. So it doesn't have to be one-sided, throbbing, in bed. You can have a mild one-sided headache that's worse with activity that can be a migraine. You also need either nausea or vomiting or sensitivity to lights and sounds. That's a definition of migraine. And people started looking at people who had lots of headaches, and there's a new definition, a relatively new definition, for chronic migraine. And the importance of chronic migraine is that chronic migraine is an undertreated problem. Chronic migraine is the most debilitating. You need at least 15 headaches per month. 8 of those headaches should be migraine. You should either be responsive to a triptan or it should be lasting 4 hours, and there should be no other cause for headache. So chronic migraine is important because it affects about 2% of the population. It contributes to a majority of the cost. These people overuse emergency rooms, take a lot of medications. It's misunderstood. If you go to a practitioner who blames it on your depression, which is a comorbid feature of migraine, your depression is not the reason you are getting your headache. You are getting your headache along with depression. Sometimes people underdiagnose it. It's amazing to me to see people who come in my office who know a lot about migraine, who talk about sinus headaches, which are probably a variant of migraine. It's mismanaged, particularly if you're not a preventive, and people use a lot of medication, particularly over-the-counter medication. Probably Excedrin migraine is my #1 overused medicine. Here's another Gary Larson cartoon. Gary Larson is from the far side. His wife had migraines. He's got a whole set of slides relating to migraines. So where are we today? We have both preventive treatment and we have abortive treatment. And I'm going to talk about these a little bit, again, from a bird's eye view. The only currently approved treatment for chronic migraine at this point is BOTOX. BOTOX is a very important piece of my treatment regimen. BOTOX is very effective. BOTOX requires injections, and when I tell my patients, you're getting the BOTOX, the migraine paradigm. So pretty much everybody gets the BOTOX in the same regions unless we decide together not to do it. The dose may vary, but this paradigm or this design was put together and tested, and this is thought to be the most effective way to give BOTOX. We give 31 little injections using 155 units of BOTOX. BOTOX decreases the number of headache days up to 9 days per month. And the important piece is that your BOTOX may not work the first time. So I set very low expectations when I'm giving BOTOX and tell my patients, if you're not better, don't be upset, because it requires at least 2 injections. And these are the muscles that are injected. Most people tolerate them very well. And as I said, BOTOX has become very important for me as one of my treatment regimens. There's another recent advent to our treatment, and this is a stimulator. This is a orbital transcutaneous stimulator. It's supraorbital, and it's called Cephaly. Cephaly is a stimulator which is thought to block the transmission of pain. This was, I think it was initially sold over Amazon. You need a prescription for it. I think it's harder to get through Amazon now. It costs about $300. The Cephaly people have relaxed their the way that you can return it if it's not working. This needs to be put on 20 minutes every day, and it decreases the incidence of migraines by about 3 or 4 days per month. It's pretty benign. People tolerate it pretty easily. This is the new sort of improved design of Cephaly. I wouldn't walk around on the street with this thing in place, but you can be identified as a migraineur. There's another device, which is a transcranial stimulator. This device is used for people with migraine. It's meant to interrupt your aura, and you need to have an aura as part of the treatment. This device is fairly expensive. I believe it's rented per month, and you know, there's pretty good data on it. It should not be used for people without aura. Talking about a little bit about these are now available. This is Onzetra. Onzetra is a nasal device. It's a device that you blow into. You blow in, you take them, it's got sumatriptan, which is Imitrex. You blow it into your nasal cavity. It doesn't have the drip of the nasal spray. It gets back into your nasal cavity, usually without a bad taste. It's got very few side effects. It works quickly. It's an alternative for those of you who are very sensitive to triptans or don't like to take nasal sprays. So where are we coming up on tomorrow? Here's another Gary Larson cartoon. And here's this is where we're getting into the meat of the matter and the CGRP. So CGRP is calcitonin gene-related peptide. Calcitonin gene-related peptide is thought to be one of the seminal neurotransmitters that contributes to the inflammation and the dilation of blood vessels. And somebody had a very bright idea. what if we can block this chemical, and how can we do it? You can see I've listed it as the most potent, naturally occurring vasodilator in the brain. We know that if you measure CGRP during a migraine, it's up, and when the migraine is over, CGRP goes down. Now, CGRP binds to special receptors that activate and cause the headache flow. And we know that CGRP is important in it being blocked with BOTOX. We don't know all the ways that BOTOX works. It's certainly not just a paralysis of muscles, but it works in other ways that we don't understand. But CGRP also probably works with the triptans. And the triptans are, I would hope, are agents that many of you are familiar with: Imitrex, Zomig, Maxalt, Relpax, etc. So again, this is the CGRP slide that I showed you, and this is from migraine.com, and CGRP antagonists are the new triptans. So, you know, we as headache physicians were very excited when when the triptans came out. The triptans were great drugs. Unfortunately, the triptans don't work for everybody. About 25% of the patient population are triptan non-responders. To me, I think that means that there's a different pathophysiology with some patients, and I think the other piece is we don't totally understand yet how migraine works. If this is a designer drug, why isn't it working it for everybody? So people have come out with CGRP antibodies. An antibody is a protein which is formed by the body to react against a foreign substance. And you see the antibodies in psoriatic arthritis, cancer, ulcerative colitis. Those are antibodies that were made that react according to, that try to block some of these common problems. But people decided they were going to set up and try to engineer an antibody to CGRP. So if you could block CGRP, theoretically, you could block the agent. And there are 4 companies that are working with CGRP: Elder, Amgen, Lilly, and Teva. These are all in stage 3 phases of being treated. We think that these drugs are going to be out in about the next year or so. We don't know how effective they're going to be. We have some ideas. The importance of these big molecules is they need to be given either through the vein or injected. So they are not going to be pills. They're given IV, or sub-Q. So somebody's going to have to give them, and you're going to have to give them relatively infrequently, because the molecule hangs around in the body for a long time. Now, I put this in here. This is another Gary Larson cartoon, because not everything is what we think it's going to be. I mean, I'm not downplaying these antibodies, but these antibodies may be much more effective than we anticipate. There are other devices that are going to be coming on the market. The sphenopalatine ganglion, which is going to be under treatment, that's going to be a stimulator for this ganglion, which is thought to be important in cluster and migraine, and a vagal nerve stimulator. These are on the drawing board. Some of them are available in Europe. The sphenopalatine ganglion requires a wire to be inserted. You've got to get basically a surgical procedure. You hold it on the side of your head and you can modulate it. And here's the vagal nerve stimulator. There are other treatments in here. There are also, I should talk about the small antibodies. The small antibodies are going to be given as a pill. And these differ from the big antibodies, the one that I showed you, because they have a much shorter half-life. So the large antibodies are going to be basically for preventive. The smaller antibodies are going to be for abortive treatment. The smaller antibodies, we've already seen, Merck was working on one, but it had a lot of liver toxicity and it was aborted. That's one of the advantages of the larger antibodies. They don't have a drug-drug interaction and they have very few side effects, but they're going to need to be injected. The question is, and we don't know this, but can you give a large antibody for your prevention and a small antibody for abortive treatment? How do you give a large antibody? Can you give it with a triptan? I mean, these are questions that we're struggling with that are going to come to fore and hopefully will be clarified. There is an agent called lasmiditan, which is a triptan-like compound. The advantage of this is that the triptan is not going to affect the heart and is going to be, it's a triptan-like compound, but it's going to be safe to give with people who have heart disease. There's another Semprana, which is an agent which can be given as an inhaler. This is a DHE inhaler, which is a cousin to the triptans. So I think, you know, we can serve up all these compounds. I think it's going to be up to the medical community to adopt them and to understand how they work, because they do work in very unique ways, foreign to most neurologists and to many primary care doctors, and that's the part where we're going to have to come in. We need to be advocates for ourselves. We need to be advocates for the migraine community. I've given you a very quick, but I hope a comprehensive overview of what lies on the horizon. And again, I thank you very much for allowing me to be here today.
We're not going to let him go yet. He's going to get to answer 3 questions. We have a couple minutes left. Do you want me to read them, or do you want to read them?
Yeah, why don't you read?
Okay. What is CGRP good for, useful for, in the body, and will antibodies to it potentially have dangerous side effects? For example, will you be blocking a key function?
That is a great, great question. You are now a third-year medical student. So I did not talk about that. I did not talk about that in terms of its potential, and I'm saying that, potential downside. We know that as age progresses, CGRP decreases. I mean, that's an interesting question, because if you get older, you have potentially a lot fewer headaches. Is it because your CGRP is not often as stimulated? But we also know that CGRP is important in lots of different organs. It's in the gut, it's in the heart, it's not only in the brain, and it has something to do with hypertension. So is CGRP protective? And the question is, if you're on a CGRP antagonist, are you subject to other problems that we haven't seen because there's been no CGRP antagonists as yet? I don't have the answer to that question, but it's certainly something that we're going to be looking at.
Thank you. Okay, the next question is, can BOTOX be used for someone under 18 years of age? Is there a big difference between pediatric and adult migraine?
Pediatric migraine patients have different kind of headaches. They're typically shorter. There's a lot of nausea with them. They are more debilitated. They're oftentimes in bed. You know, as an adult neurologist, I see kids from 12 on up. I've made that dividing line because I feel comfortable with treating young teenagers. BOTOX, I believe, is only indicated for people over 18. But I think if you've got somebody who is 17 and would be a good candidate for BOTOX, that's where you've got to get your doctor to write a letter of appeal. I mean, between 17 and 18, I mean, we're not talking about there being a big obstacle to that. We're talking about several months. So if there's somebody who I think is 16 or 17 who could benefit from BOTOX, you know, I think the piece here is to get your physician to write a letter of appeal.
And now the most controversial question, saved for last. Can you talk about the use of medical marijuana?
The American Academy of Neurology has come out with sort of a marijuana position statement. Marijuana is important in neurological practice because it includes headache, pain, MS, seizures. You know, and our organization, I think, has been very responsible because they're looking at any agent that meets the criteria for rigorously tested. They're not looking at somebody who happened to respond to marijuana and it stopped their seizures and there's 3 kids in the country, and I'm not downplaying that. But there needs to be good medical science backing up our decisions. There is really no good evidence that marijuana works for migraine. I mean, I can give you 5 ways that marijuana may work for migraine, but it may not have anything to do with migraine. I mean, it may make you less anxious. It may make you, instead of getting dehydrated, you feel like you want to eat and drink, and that helps your migraine. I think I have people who do use marijuana. Marijuana is not approved in Pennsylvania. I tell them, you know, I can't condone that. If you want to use, that's up to you. I've never prescribed marijuana. But I think the answers are not all in. And a lot of that is because we don't all totally understand how marijuana works, but I think we also don't understand all the intricacies of migraines. That's why when Imitrex came out in the mid-'80s, early '90s, I mean, here we are in the 2017 starting to look at antibodies that nobody could have ever conceptualized when Imitrex came out, because now we have a better understanding of migraine. And I think with that better understanding, agents like marijuana are going to get a second look because they may work in ways that we don't appreciate as yet. Thanks. Thank you very much.
Yep. Thank you, Dr. Schulman.